Thank you, Jeremy, for that introduction, and it's a real pleasure to be here at the annual conference for SI UK and to see so many friends here. I'm slightly nervous for two reasons, although I'm an experienced speaker. Firstly, is that you're always nervous when you've seen previous speakers struggle with the lights or the slides, so I'm hoping that that will work well. And of course, I'm also slightly nervous because I'm presenting in front of Jeremy Pearson and Carol Black, who are two of my most influential and important mentors in my own personal sort of trip through scleroderma over quite a lot of years now. But I just wanted to make a point, and I'm going to give two talks today, and I'm very grateful for that opportunity. And they're interlinked, and I hope that those of you that stay for the day will sort of see the arch theme, really, which is the first talk is going to really be on how we can do the best we can with what we've got at the moment to improve treatment and outcomes for systemic sclerosis, for scleroderma and Raynaud's. And the second will be a little bit more forward-looking into sort of some of the new and exciting emerging treatments that might hopefully improve and give us even more opportunities. So what I'm going to talk about first of all really is to talk about evidence-based medicine and practice in systemic sclerosis, and how we've really tried to follow and in a way grow up a little bit, I think, as an area of medicine to try and practice, to develop guidelines and recommendations so that we can truly say that we are practicing evidence-based medicine, and also to really emphasize that it's not just about the treatments you give for patients, but also how you approach the investigation and screening and management to make sure that you identify problems as soon as possible in the disease. So I'm going to talk a little bit about evidence-based medicine and management of scleroderma. I'm going to present specifically the British Society for Rheumatology and BHPR guidelines that were published in 2016 now, which went through a very rigorous process. And I'm going to also mention some of the other evidence-based guidelines that are now available that do allow us to sort of have a better idea about how to standardize scleroderma treatment. And I'm really going to focus on not just the medical aspects of treating the condition, but also the importance of regular investigations. Whenever you make a diagnosis of scleroderma or Raynaud's, how you should investigate patients, and also how you need to keep doing that through the course of the disease to make sure that you can really treat complications effectively when they develop. I wanted just to give one little bit of background to give context to how guidelines and recommendations are developed, and that is just to consider two concepts, which are the level of evidence that we have to support a practice or a treatment, and also the grade of recommendation that we can make about whether that treatment or that investigation should be performed. So levels of evidence are really about the degree to which we've got scientific research, usually through clinical trials, to really robustly be sure that the drugs we're giving are safe and effective. This is a real challenge for systemic sclerosis because it's a rare disease, and as we've heard, there's been progress in developing infrastructure in organizing research, and a lot of that's been supported by SI UK and by the predecessor organizations. But it is, in the end, a rare disease, and therefore very hard to do large clinical trials like you might do in high blood pressure or diabetes or other commoner medical conditions. And so it does mean that we're always struggling with getting those very high levels of evidence from those sort of randomized controlled trials. And we have to move down and think about what can we do if we don't have large trials. And we can have perhaps smaller trials that may not be quite so scientifically robust, but perhaps when you put them together, they can be really still give quite a compelling message. And we can rely on our experts, and that's again where groups like the UK Scleroderma Study Group have been very helpful and very important. And we should say that in all of our efforts to develop recommendations and guidelines, we always have very strong involvement from patient organizations, from a range of professionals, and also, of course, from patients themselves. And all of the recommendations and guidelines I'm going to mention have all involved patients in the working groups as they've been developed. So once we have the evidence, we can then put that evidence together and as an expert group often come up with what we call a strength of recommendation. So if we have really strong evidence that this is an effective therapy, we can have a grade a recommendation. But if we move down and we've just got sort of expert opinion that this is a good thing to do, then we can have a much lower grade of recommendation. And this helps us to identify areas for future clinical research and future priorities for trials and investigations. So we're not the only group in the UK who've tried to develop recommendations or guidelines to treat systemic sclerosis. The European group, which the UK is very much part of, the EULAR and EUSTAR groups, have also worked on this, and in 2009 they published the first set of recommendations. What it became apparent when we developed these recommendations, and I was part of the group that did this, was that it was very much restricted by the process, in that EULAR are very concerned to have high-quality evidence, and really, unless it had been published in large clinical trials, we were not able to make recommendations about treatment topics in scleroderma. So whilst it was useful to have these recommendations, and they turned out to be a sort of series of recommendations about specific aspects of scleroderma, they were in no way comprehensive, because they could only really give recommendations about areas where there'd been a significant number of clinical trials, which, as I've said, are relatively challenging in scleroderma. The guidelines were updated, so in 2016 there was an update published of these, and again, because there were more trials published, it could sort of cover a slightly broader range of problems that scleroderma patients have, but it was still really quite a limited approach. And it was that background that really, I think, led us as a scleroderma community in the UK, and also supported by the British Society for Rheumatology, to identify the need for a guideline that was perhaps more UK-specific and was more comprehensive. And this is really what underpinned the development of the BSR guideline for systemic sclerosis, and that's what I'm going to present something of today. So it took quite a long time to get to the stage where we could publish this, and it is now published it was published in the Rheumatology Journal. It's available online as a summary and also as a full document that anyone can download. So any doctor or any clinician caring for patients, or indeed any patient, can download these guidelines to see what's the evidence and what are the treatments available. And I should emphasize that although I was coordinating it, it was very much a group effort that included patients, all of the sorts of professionals and allied health professionals who we need to help in scleroderma, pharmacists, specialist nurses, as well as representatives of all the key scleroderma units around the UK. And it was organized and coordinated through the BSR process. And the BSR process, the important thing is this is NICE accredited. So the BSR has a process to develop these recommendations that are accredited by NICE, meaning that when we came with the final guideline, it does come with the stamp of approval of NICE, which is certainly very important in the NHS these days for sort of moving forward and getting funding for drugs and treatments. So it was a long-term project. We actually started it at the end of 2012. It took at least 3 years, really, in a series of face-to-face meetings and discussions and literature review and all of the things you need to do to develop a guideline. But we did actually almost reach our target. We had an original target to complete it in September 2015. In fact, we finished it around December 2015, and so it was published after peer review and review through quite a rigorous process to get this NICE accreditation. It was fully published in 2016. So I'm going to take you through a little bit of the guideline, and it covers 3 areas, really. The one was, and these were all identified as important areas for patients and for specialists. The general approach to systemic sclerosis or scleroderma, how we actually treat the complications when they occur, and we really wanted to include a part that was aspirational about how we would improve and what we would see the future for developing scleroderma centres and scleroderma services in the UK and within the NHS. And this was something particularly we were targeting clearly to NHS England and to the providers of healthcare. So at the beginning of our exercise was, if you like, what we came up with as a roadmap to treatment for systemic sclerosis, and it's summarized here. And of course, there are quite a lot of aspects behind this, but the first thing, of course, is we need to have robust diagnosis of systemic sclerosis, of scleroderma, so that patients were identified. And of course, as we've heard about, it's very important to try and identify and diagnose the disease as early as possible. But then one of the challenges in scleroderma is that no two patients are the same, and in fact there are different groups of patients, and you can at least categorize patients into those that have more severe skin involvement, diffuse scleroderma, those that have the limited form of scleroderma with less severe skin involvement, and those that have, in fact, not just scleroderma, but also another rheumatic disease, the so-called overlap scleroderma patients. And we know that this is about 20% of our patients that we see in our centre have lupus or arthritis or vasculitis or something else that needs to be treated as well as the scleroderma. But what we realised was that, in fact, although you could separate patients in these different groups, we also knew that there were shared features when we're trying to treat patients. We definitely need to focus on the vascular aspects, the Raynaud's and the complications in the blood vessels for all forms of scleroderma. We needed to think about immunosuppression, particularly for the diffuse form, for that early aggressive form of the disease. But in fact, the most important thing really was that we were able to really highlight the priority of identifying the complications of the disease, not just diagnosing it, but finding out how it was affecting an individual patient so that we could really treat the complications that occurred in the heart, the lungs, the kidneys, but also an appreciation that as well as these life-threatening problems that are often more of a concern to doctors, that there are those common aspects of the disease that affect everyone with scleroderma: Raynaud's, calcinosis, gut involvement, incontinence, and so on, calcinosis, all of those problems that need to be addressed. So we wanted to be very comprehensive as we approach the disease. And this is really for a sort of a medical audience, if you like, but just from a recent review article that just highlights the diversity of the problems that patients have, and many of you, of course, will be very, very familiar with all of these, the heart, the lung, the kidney complications, but as well as these non-lethal aspects of the disease affecting the hand function and calcinosis and digital ulcers. So we wanted to cover all of this. So I'm just, first of all, though, want to just take a step back and say that it's not important just treating the complications. You first of all got to detect or diagnose them. And Professor Black made the point that we have improved outcomes over the last 20 years in systemic sclerosis and scleroderma, and this is shown here in these two graphs that were taken from an analysis of the patients that come to see us at the Royal Free. And it just highlights that if you have the diffuse form of scleroderma and you presented to our unit in the early 1990s, you had quite a poor long-term survival. At 5 years, there was less than 70% survival. But a decade later, in the early 2000s, the survival had improved. And although survival is clearly not the thing we're aiming, I mean, not the only thing we're aiming for in systemic sclerosis, it's a sort of quite a crude measure, but it does really represent improvement in how we look after the disease. So that was an interesting observation, but much more important was when we actually tried to understand what was different between 1990 and 2000 in the way that we were approaching patients. And what was really the difference was that instead of being what we might call reactive, so waiting for a patient to present with a clinical problem and then treating it, and treating it as aggressively and as actively as we could, we'd changed to be proactive, which I really wish this slide controller was. There we are. So that we could try and anticipate things, if you like, and treat them at an early stage. And so that in fact, if you look at these graphs, which are also part of this study, you can see that in fact they're almost the wrong way round, because when we were in the modern era, we systematically do tests as soon as a patient presents and then regularly during follow-up to determine whether or not a patient's developed a heart problem or a lung problem or a kidney problem. And as soon as we do that, you can see that actually in the modern era, in the 2000s, we detect this quite high rate of lung fibrosis or pulmonary hypertension in our patients, compared to the historic era where we wouldn't have been aware that there was a problem, but clearly there must have been. And the one complication that you can never miss, if you like, as a scleroderma physician is renal crisis, because renal crisis, of course, if you don't find it, it will come to find you, because a patient will get very, very seriously unwell very quickly. And so we know that the scleroderma patients that we're looking after now or that we were looking after in the past were equally susceptible to these complications, because you can see that, in fact, for renal crisis, there was almost no difference between patients and those after that 10-year interval. So what it shows is that if you go looking for problems and find them earlier, even with the treatments that we have today, which are not cures, we can do much better, and patients do much better with the disease. So if we put that together, here's just a summary of those tests that we should do in a scleroderma patient when we first make the diagnosis, and then regularly and typically on an annual basis when we follow patients up. And many of you who come to any of the scleroderma clinics will know that most years you will be asked to have a lung function test or an echocardiogram and have a series of blood tests. And the reason for this is that we want to detect whether or not there's any evidence of pulmonary hypertension, of severe gut disease, heart problems, scleroderma renal problems, and in particular lung fibrosis. So these lung complications, as I showed you on the previous slide, these are the things that's really made a difference, detecting them early before a patient becomes severely breathless so that we can start to initiate treatments. So that's very important, and that sort of underpins really how we manage patients with scleroderma. And if you don't find the problem, you can't sort of proceed with the treatment. So I just want to, just in a few slides, go over a few snapshots of examples from the BSR recommendations that has helped to sort of to try and standardize treatment and also to sort of set standards for treatment. So these are the way that the recommendations are sort of synthesized in the end. So general approaches, so the first part of the recommendations is sort of general approaches to the management of systemic sclerosis. We recognize that diffuse scleroderma is a real priority. Of course, we want to diagnose all cases of scleroderma, but diffuse scleroderma needs to be diagnosed as soon as possible because of the high risk of complications early in the disease. So we really want to emphasize the importance of referral to a specialized scleroderma center if you have the diffuse form of the disease. And we think all patients should really have that, ideally within the first year of the illness, so that they can be properly assessed and also be considered for clinical trials. We think, and this has really come from work and research, some of which is supported by SR UK, into the use of immunosuppression for scleroderma, that all patients with diffuse scleroderma should have a form of immunosuppressive treatment to help the skin and hopefully help the lungs as well. And we should avoid drugs that don't work, like D-penicillamine. So we do have some evidence of drugs that definitely don't help scleroderma. We need to consider stem cell transplantation in those patients with the most severe disease or those patients at particular risk, and I will just show how that's sort of moved forward a little bit later this afternoon. And so we need to use immunosuppression, and we summarized the evidence and the grade of recommendation for immunosuppression for scleroderma patients and highlighted the drugs that might be considered. And it's important to list these drugs because then it helps when you're applying for funding for a treatment for scleroderma if you can say this is a drug that's recommended in an evidence-based guideline. And we also emphasize the importance of long-term treatment. So patients with scleroderma don't just need treatment for the first year, they need treatment often for a number of years. And I don't have time to go through the sort of bulk or the second part of the guideline, which was really picking out the best treatments for all the major aspects of the disease. So Raynaud's and digital ulcers, lung fibrosis, pulmonary hypertension, gut and kidney problems, heart disease, skin, calcinosis, musculoskeletal problems, and of course stem cell transplant for appropriate patients. But I just wanted to highlight from the list that we didn't just stick, as perhaps other guidelines have, with the treatments where we've got evidence based on trials, but we did highlight things like calcinosis and areas and musculoskeletal problems that we don't really have good treatments for. But this was really, again, a message that came through from patients and from the broad range of people looking after scleroderma patients, that we need to focus on all aspects of the disease. I'll just give you a couple of examples, though, just because they're things that will really affect almost every patient with systemic sclerosis. The first was the recommendations we had for Raynaud's phenomenon. So we know that essentially everyone with systemic sclerosis will have Raynaud's to some extent, and so many of you here will be very familiar with this. And we were able to highlight the importance. Again, we wanted to emphasize this holistic approach, that lifestyle changes and even things that aren't necessarily drug therapies are things that patients find helpful. So again, it's in the guideline and can be seen as a serious part of treatment. And then the various drugs that we have, that we know that if you use them in combination, even though the evidence base is not perfect, that these seem to be helpful for patients. And that includes some of the newer drugs like phosphodiesterase inhibitors. So this is drugs such as sildenafil or Viagra, which is now available and very helpful for patients with severe Raynaud's in some cases. So it's, again, very important, and to emphasize that other treatments such as botulinum toxin might be considered for difficult cases. We may hear more from Professor Butler about that later today. But these treatments do work for digital ulcers and for Raynaud's, and we've put things together with the various drugs and surgical approaches, and we know that we can heal digital ulcers with these therapies. So patients are doing better than they were with this more organized approach to therapy. And I should just say that as well as the BSR guideline, the UK study group came up with consensus best practice recommendations for a number of key areas. Professor Herrick led this one, which was about digital vascular disease, Raynaud's, digital ulcers. And we've published these as well, again, in an attempt to really improve awareness and priority for these problems. So part of that work on vasculopathy and the recommendations led to the NHS England policy for digital ulcers. So it sounds a little bit bureaucratic, but it's terribly important when you have a treatment, and especially a high-cost treatment, that you get endorsement from NHS England to fund the therapy. And we spent about 18 months negotiating with NHS England as scleroderma experts and really trying to get to the state where we had access to these therapies for digital ulcers, and specifically for a drug called bosentan, which is an endothelin blocker that's expensive, but has been shown in 2 clinical trials to work for patients with severe digital ulcers. So we came up with a management approach and an agreed strategy and a policy that was published. And this, once you have a policy published from NHS England for a treatment of a complication, this should mean that you have equal access to this therapy across, certainly across England and Wales within the NHS. Just to show you how that worked, so this drug, bosentan, really did transform outcomes for some patients. Here's one of our patients, and we published this case, who had very severe digital ulcers on lots of digits, had to come into hospital 3 times a year for prostacyclin, for iloprost therapy, and was finding it very difficult to work. This patient went on to bosentan, this endothelin blocker, and all of the ulcers healed, and that was a tremendously positive outcome, as you can see here, and the patient no longer needs to come into hospital regularly for iloprost. That's an extremely good outcome, and we're not suggesting all patients respond that well, but it does show how implementing these policies can be very important for patients. Just wanted to briefly talk about pulmonary hypertension, which was mentioned earlier. So this is now a very treatable complication of systemic sclerosis. It's very important to detect it. I showed you how through our screening we can do that. And in fact, we've worked even harder to screen patients for pulmonary hypertension and develop improved methods for doing that. We know that once you've had scleroderma for about 3 years, about 1 in 100 patients will develop pulmonary hypertension each year as we follow them up. So it's very important to be vigilant for that. And we know that about 2/3 of those patients that get pulmonary hypertension will have a form called pulmonary arterial hypertension, which is now very, very treatable. So working internationally and in collaboration with Actelion, who manufacture and developed bosentan, we were able to develop something called the DETECT score. And the DETECT score is a smartphone app, not for patients, but for physicians in the clinic, where they can put in all the tests that might be relevant for a patient with scleroderma and get a score out of that as to whether they're at high or low risk of pulmonary hypertension. And that helps us to be even more effective in not missing the diagnosis. And the reason why we don't want to miss the diagnosis is because we've got evidence-based treatment and a lot of drugs, in fact, now 11 different drugs, all licensed for pulmonary hypertension in scleroderma. The treatment is coordinated through specialist centres across the UK. And so if you get pulmonary hypertension these days, you can have access to these treatments. And even more importantly, we know that these treatments are evidence-based. When we had the first of these drugs, bosentan, the drug that also works for digital ulcers, you can see that it immediately improved outcome for our patients. You can see the upper line showing the 5-year survival of patients with pulmonary hypertension once we can treat it. But now we can do better than that, and in the more recent large clinical trials that have looked at long-term benefit, we're really confident now that with early combination treatments using these licensed therapies, we can reduce the risk of progression or death from pulmonary hypertension to about 50% of what it used to be. So this is a major treatment advance. Just wanted to briefly mention stem cell transplant. There's a lot of publicity about this very intensive treatment, very intensive immune suppression, life-threatening, in fact. So it's a treatment that if you didn't have very, very good medical support, you could die just from having the therapy. But it can be associated with good long-term outcomes. And I'll talk a little bit more about that in my second talk today. But because it is available and because it's now evidence-based based on some clinical trials, this is a treatment we feel that should be available in the UK. And again, we worked closely with the specialized groups in rheumatology, but also in bone and blood transplant with the hematologist to come up with a pathway so that patients within the NHS can get appropriate referral and consideration for this treatment. So finally, I just wanted to just highlight the third part of our recommendation, which in some ways I think is a sort of, from my perspective, is one of the most important. And this is really the vision for the future of how we improve organisation for scleroderma care in the UK. And it really just highlights in some bullet points. But again, I think it's very important to have this in a nice accredited NHS guideline. That scleroderma, systemic sclerosis, needs to be managed in an integrated system of primary, secondary, and tertiary care. That means GPs, local hospitals, and specialised hospitals all working together as a team. In secondary care, in the hospital care, you must have a multidisciplinary team. It seems obvious, I think, to us and to patients, but it's very important to see that healthcare providers understand the importance of having a specialised team. And we must have lots of education. We should have specialist nurse-led clinics for some of the complications of scleroderma and really good support from things like telephone helplines. And finally, of course, really an endorsement of the importance of having patient engagement and patient organisation engagement. So the Scleroderma and Raynaud's UK is a very important part of really optimal care, we think, for scleroderma as we move forward. So this is almost my last slide, and it was just really my 21st century vision, if you like, of how we should be looking after systemic sclerosis and really trying to make the strides forward that we think should now be possible with more clinical research and hopefully more investment both for research but also in service providing in the UK. So we think that there should be scleroderma specialist centres. We've got a number around the UK, and they should be supported because they provide a very important resource for patients for coordinating care, but also for coordinating the involvement of other specialities that need to be involved: pulmonary hypertension, cardiology, dermatology, gastroenterology, renal medicine, and so on, and of course surgery. And all of these are very important because someone has to take charge of the management of scleroderma patients and make sure that things are done in a coordinated way. We also need to make sure that patients can flow very well from primary care or from their specialist, like a rheumatologist or dermatologist who might see a patient first and suspect the diagnosis, that there's a sort of good flow so that the right patients are assessed. And we also need, this is very important, that there's sort of stakeholders, including funders and NHS England and all of the European and international organisations, can really sort of contribute and help us develop this organised care. And of course, under this needs to be a lot of high-quality training and clinical and basic science research so that we can sort of take the next steps forward. So I'm going to finish there. If there's a couple of minutes, I'm very happy to take questions, and I just wanted to acknowledge SRUK and other funders of our work and colleagues. Thank you very much.